Good afternoon. I'm Anthony Leeds. I chair the Total Diet and Meal Replacement Europe industry group, and it's my great pleasure to welcome you this afternoon to our seminar in which we will look at the evidence for possibility of achieving diabetes remission, but also address the question of how people can maintain weight after they've achieved a good weight loss, which is necessary to achieve remission. And this is in fact a very important issue. We don't have all the answers, as you'll see, as we present the evidence and discuss the questions. We are very fortunate today that we have some very significant speakers who have contributed to the research base. But if I may go to the next slide, please, just to deal with issues that relate to housekeeping. Would you please put questions on the chat line? But please also give your name and the institution in which you work to help us know who's asking the question and the background that you come from. That would be extremely helpful. We may not be able to answer all the questions that will appear, and of course we'll do our best afterwards to do these by email. It's important for me to tell you that the presentations, the abstracts and the slides will be made available online after the event indefinitely, so that if you miss anything, we'll be able to supply those to you. And you can see the address on which you could email to obtain those, although we will put them on the website in due course. If you do experience any technical problems during the course of the presentation, then there's an email address at the bottom of this page that you can communicate with Denise, who's on the team delivering this web seminar. May we move on to the next one, please? So this afternoon we have three speakers. Michael Lean, who's works at the University of Glasgow, who's going to describe for us the diabetes remission trial, for which he's a co-principal investigator, but also to discuss the question of how much evidence we have and how this can influence guidelines and what guidelines are currently being developed. We have Gary Frost, who's going to talk to us about the challenges in relation to weight maintenance. As you know, he works at Imperial College in London, and Elena Philippou, who's very kindly joining us from Nicosia in Cyprus. By background, she's a dietitian, but has done a great deal of work on diet in relation to weight maintenance, but particularly to glycemic index and low glycemic load diets. And at this particular point in time, before we start our talks, it's obviously very important to recognize that Europe, and indeed the entire globe, faces major challenge relating to obesity and obesity-related comorbidities. The one that we normally have at the top of this is diabetes, because the prevalence rate for diabetes is rising rapidly. And globally, while some countries are able to manage this well, there are many countries, particularly in the lower middle income ranges, that are not actually able to address this rapidly increasing challenge. It's known that weight loss is a very important component of diabetes prevention, but also for diabetes management. We will touch on that during the course of the afternoon. So I'll stop at this point then, and I will introduce Mike Lean, who is the Professor of Human Nutrition at Glasgow University, Principal Investigator of the study that's been reported in relation to diabetes remission, and then also, of course, has worked in lots of other areas as well, and has a very large team of research workers and a very large research output. So Mike, thank you very much for joining us this afternoon, and we look forward to hearing your talk.
Thank you very much indeed, Tony. And I'm very pleased to have this opportunity to share some aspects of our work and to tell you a little bit about how this is having impact across clinical practice and guidelines, not just in the UK, but indeed worldwide. So I'll crack straight on with sharing my screen. And hopefully we'll be able to get this up and running.
Yes, it's showing now, Mike. Thank you.
Thank you very much indeed.
Do you want to put it on full screen? Yes, it's on full screen. Thank you.
So it's going like a rocket now. There we have technically some disclosures here, which you can see. And I'm also mentioning that the many of the slides which we use and in all the papers from the direct clinical trial are up on the website, which is called www.directclinicaltrial.org. That's org.uk. Now, the starting point here, I'm a doctor. I've looked after people with diabetes for many years. And I think when I started my career, I regarded this, as many do, as a a sort of hallmark of seniority. It's something which happens with age, obviously in people who are a little more overweight. But we didn't worry about type 2 diabetes too much. We gave people a pill. We said, come back in a year's time. And sometimes we had to add another pill to that one. What we hadn't realized was the disease, of course, is occurring now in much younger people as they become overweight at younger ages. And the mortality rate, or the life expectancy and survival rates with type 2 diabetes, are now really rather similar to those of some quite major cancers. And here are some numbers for you. This just shows on this slide the 10-year survivals of breast cancer, 80%, which is actually quite good. Non-Hodgkin's lymphoma, not very good at 60%. Type 2 diabetes, on average, 50%. They come from different databases. They're not exactly comparable, but they're in the same order, same league of seriousness. We should be taking type 2 diabetes as seriously as we do some quite major cancers. And I think across the profession, we don't. And we're having to move in that direction as a big learning. We know and have known for many years that type 2 diabetes is very strongly related to becoming overweight and obese, not with a BMI of 30 or 28, but as the body mass index rises above what we used to call ideal body weight. So a body mass index of 23 or 24 is already showing very major increases in the risk of type 2 diabetes. This is a relationship which can only be causal. And we know that populations who keep their body mass index around the 21, 22 level very, very seldom develop anything like type 2 diabetes. It's a very rare disease indeed. We've also known for many years, and there have been many studies now showing this, that people with pre-diabetes, who we can detect with an elevated hemoglobin A1C, not yet in the diabetes range, if they are able to lose weight, just of the order of 7 or 8 kilograms, this will prevent the development of more than half of the diabetes in that population. And that is maintained for at least 4 years. Indeed, we have data now going up to 10 years showing that this quite modest weight loss is able to offset the development of diabetes for up to 10 years in about 20% of people. So this is a disease which is very, very closely related to weight gain and is not dependent on reaching any cutoff of BMI 30 or anything like that. Now, bariatric surgeons have for years said that they could see type 2 diabetes disappearing, a remission, if you like, as people lost weight with major weight losses. And they're looking at often weight losses of 30 or 40 kilograms. And I asked the question, how much weight do they need to lose to get rid of their diabetes? And John Dixon in Australia conducted a very small randomized controlled trial here. And these are the individual patients who were in this trial. They all had type 2 diabetes and all had a BMI over 30, in fact. Half of them went into the arm which had gastric band surgery, and you can see their weight losses there. It's as a percentage of weight change, but that's exactly the same as kilograms weight change because they were on average 100 kilos. And the usual diet on the right. The filled symbols are those who remain diabetic after 2 years. And you can see with usual diet, there were in fact 2 individuals who had lost quite a lot of weight who were no longer diabetic. With gastric surgery, most of the patients, indeed 73%, were no longer diabetic after 2 years. So 73% overall, and that's very typical of the results we see from people with type 2 diabetes who have bariatric surgery. And I put a line here at 15 kilograms. John Dixon himself put it at 10 kilograms. And above that line, whether it's 15 or 10, it doesn't make any difference because there's so few patients there. 83% who had remission, who had weight losses of 10 or 15 kilograms were in remission. So over 80% of people were able to achieve a remission if they lost more than 15 kilograms. These data, we then took back and said, can we try to do something like this in real life with ordinary people without bariatric surgery? And that was what led to the direct clinical trial. And myself and Roy Taylor in Newcastle, ultimately, after many years of not being funded, ultimately got funding to do this study. And it looked like this. This was a study conducted entirely in primary care. Nobody came anywhere near a hospital. The intervention was delivered by a nurse or a dietitian if there was one available in primary care. They saw the GP once at the beginning and occasionally if there was a problem, but otherwise it was managed by usually the nurses. And we had a very good team, Counterweight team, delivering the program which is called Counterweight Plus, which we developed for this purpose, which is now commercially available. And the study looked like this. On day 1, we asked our patients to stop all their diabetes drugs and all their blood pressure drugs. And that was a radical thing to do. It had two purposes. One, it was a safety measure because we did not want people to go onto a weight loss program and risk hypoglycemia or postural hypotension. And these are very real risks if people continue to take their medication. Secondly, we know that people do not like taking these medications lifelong, and it was a huge incentive to them to stick in, to get involved with the program and to try to lose the weight. They then went on to a total diet replacement phase, roughly 830 calories a day, for 12 weeks. And that we allowed people, perhaps we shouldn't have done this, but we did allow them to take holidays, take breaks. We wouldn't do that with cancer chemotherapy, but with this we did, to try to keep people on board, up to about 20 weeks. And then they went into weight loss maintenance through a period of introducing meal by meal normal foods. And by normal foods, I mean normal for United Kingdom. And they're shown, on this slide here. So the total diet replacement, a totally ordinary, total diet replacement, which was inevitably going to be high in carbohydrate for palatability and relatively high in protein, but not very high in protein. We introduced physical activity advice only at the stage when they were going into weight loss maintenance, gave them counters. In point of fact, I can cut through this, there was no increase in physical activity in this group, although we tried our level best to get them to take more activity. They didn't, they were not able to. The food-based program for maintenance was typical of the UK, around about 50% of energy from carbohydrate, 35% fat, 15 protein. So it wasn't high in carbohydrate, it wasn't low in carbohydrate, it was totally normal. And the aim of that was principally to optimize the likelihood of long-term maintenance of that diet plan. We also introduced what we call rescue plans for anybody who regained more than 2 kilograms, to catch it, nip it in the bud, to catch people before they put on large amounts of weight, and to give them the chance to get back on task. And that was a good incentive. People liked that option. And we published some evidence to say that it was effective. The weight losses and remissions have been published in a number of settings now, and you can see them here. So the most exciting and dramatic result was this result with 15 kilograms or more weight loss, which achieved 86% remissions at 1 year, 82% at 2 years. So these weight losses were very well maintained, provided the patients were able to maintain 15 kilograms weight loss. And you can see for 10 kilograms weight loss, the remissions were actually also equally, in fact, better maintained, if you like, with almost 80% of patients at 2 years in remission if they were able to keep off 10 kilograms of weight loss. So for this population, if you put these two together, you could say that well over 70% of patients, approaching 80%, were able to achieve remissions at both 1 year and 2 years if they could maintain that weight loss. And with some remissions with lower weight losses, these were usually people whose baseline hemoglobin A1C was very close to the diabetes threshold, so they had very little improvement to make. And for this study, we'll come back to this, the definition of a remission was hemoglobin A1C no longer in the diabetes range, so below 48 millimoles per mole or 6.5%, without diabetes medication for 1 year and then 2 years. These are dramatic results which certainly turned heads and changed practice. We were also able in the same study, and this is my colleague Roy Taylor did mechanistic studies here, which showed quite dramatically that as patients lost weight, on the left are the responders, people who achieved remissions, and they're in the blue. And as they lost weight, their liver fat fell, their export of fat from the liver into the bloodstream, VLDL cholesterol fell, and the fat in the pancreas fell. And in parallel with that, there was then a stepped restoration of the insulin secretion from the pancreas. Now, when I was a medical student, I was told that type 2 diabetes involved insulin resistance and then death of the pancreatic beta cells. They were no longer able to make insulin. And this is just not true. We've had to change our complete understanding of type 2 diabetes now to recognize that if there is weight loss, adequate weight loss, and this is within 6 years of diagnosis, so it's possibly not with very, very advanced, long-standing disease, but up to 6 years is quite a big window. If they can lose that weight, the beta cells will steadily regain their capacity to make insulin. It's not a permanent loss of function. And in the patients then who in the this colour, this sort of greeny blue colour, are those who did not respond, and you can see they did not have that fall in liver fat, and their VLDL actually went up, and they did not have the improvement in pancreas fat or in insulin secretion. Those in yellow are the people who had a remission at 1 year, oops, I've done this again, and who then regained weight and became diabetic again at 2 years, and you can see that their liver fat went back up, VLDL went up, and their pancreas fat was no different from normal. That can be seen here in this next slide. The images, MRI images of the pancreas are shown on the top here. On the right is a person who never had diabetes. So this slide on the right, somebody who has a normal pancreas. On the left, starting from the far left, is the pancreas of people who were type 2 diabetes, and it's a ragged, thin, very small organ, which gradually fills out to become normal after 2 years. The volume increases, the raggedness, fractile dimension, it falls, and the insulin secretion gradually comes back to become absolutely normal after 2 years. Dramatic change in our understanding of this disease. It is part of the disease process of obesity. I mentioned we stopped the blood pressure medication. This was a safety measure, and here are the data which shows how safe it was. In the white line are people who were not on medication. Their blood pressures fell dramatically over the first 2 or 3 weeks, and these are the visits during total diet replacement, to end up 10 millimeters of mercury below baseline on average. So half the patients had bigger falls than that. In yellow are the ones who are on 1 medication, in green those on 2 medications, and what we can say is that there was no sudden rebound of hypertension. The blood pressures gradually fell, and at the end of total diet replacement, they were all around about 10 millimeters of mercury below baseline. We'd have to say, though, that there were about a third of the patients who'd been on medications, and those are mostly who'd been on 2 or more medications, did have to restart some of their medication within that time, at an average of about 6 or 7 weeks after starting total diet replacement, as their weights began to sort of level out. So some of them did have to go back onto medication, but less than they started off with. Now, I'm cutting through there are publications on the economics of this, which is a very big issue for health services. And publications have shown now, and this is in Diabetologia, published last year, that this intervention led people to live longer because they had fewer serious adverse events. We predict a longer life because they're no longer diabetic, no longer hypertensive in large numbers. They were likely to live a little longer. They certainly feel better. Quality of life was greatly improved, and that's a big issue for people with type 2 diabetes. And the cost of providing this service, the entire intervention service in routine medical care in the National Health Service of the UK, costs less than not providing it. So there was a saving from providing this service over a lifetime. So it's a sort of win-win-win intervention. I mentioned the criteria. There's been a great deal of discussion about the criteria for remission, even the terminology. What do we mean by remission? I think we don't use the word cure because I think it's plain to anybody in the field that if people are able to get free from diabetes with weight loss, then it's very likely that if they regain weight, it'll come back again. And that seems to be exactly true. So we use the term remission, meaning they're no longer in the diabetes category. And that has huge social issues and indeed financial issues for people. It requires a definition based on the level of blood glucose, or nowadays hemoglobin A1C, and also a duration over which it's been measured without medication. The reason for that is twofold. Firstly, of course, hemoglobin A1C settles down over about 6 or 8 weeks, perhaps a bit longer. And secondly, the effect of medication can be quite long-lasting. So it's important to have patients off all glucose-lowering medication for a period of time. The criteria which have been used over the years, there was a statement from John Booz and his colleagues in the American Diabetes Association, which actually looked for a hemoglobin A1C below 42 millimoles, below 6%. That is no longer pre-diabetic, and that's a pretty tall order. And they didn't require any duration. It was just a shot, an early shot to try and get us thinking about it. We published criteria in 2017 suggesting that the hemoglobin A1C below 48 for 3 months would be a reasonable cutoff. And another group in the UK, the ABCD-PCDS group, don't worry about it, suggested that if it's going to be by weight loss, the evidence should also include improved blood pressure and lipids, so it's going further than just hemoglobin A1C. However, to cut through this, at the end of last year, an internationally agreed set of criteria were published from the American Diabetes Association, European Association for Study of Diabetes, Diabetes UK, and the Endocrine Society, and the Diabetes Surgery Summit, which all agreed that a hemoglobin A1C below 48 millimoles per mole, 6.5%, for over 3 months without medication constitutes a remission. And of course, you then have to check up. This has to be a repeat check in a few months' time, let's say a year's time, to ensure that the remission is continued. And if it's not, then get started on getting it back again. So those are now international agreed criteria that help us a great deal. The importance, I mentioned the sort of psychological aspect of this, but of course, being in remission is likely to avoid or delay the complications. Within the direct trial, we saw significantly fewer serious adverse events in the second year after weight loss compared to the control group. So there's a very real prospect that we might see fewer complications over a longer period of time. There's a very strong sense of self-empowerment for people with diabetes if they can gain a remission without medication, which they don't like. They lose that stigma. And then there are these issues around the costs of life assurance, of their mortgage or travel insurance for people with diabetes, which if they're in remission, they're no longer diabetic, they don't have to pay. So far, 2 studies have reported remissions of diabetes as the primary endpoint from randomized trials. And here they are. Direct, I've told you about at the top. The TDMR trial was conducted in Qatar very soon afterwards using an almost identical protocol and intervention. They got even better weight losses. Direct had an average of 10 kilograms at 1 year. TDMR is 12 kilograms. And they had even better remission rates, 61% at 1 year compared to 46% overall in direct. And the reason for that was probably twofold. They had a slightly younger population with shorter duration, up to 2 years of diabetes, whereas direct we had up to 6 years, and that probably made a difference. The other thing which was important was that by this stage, people had heard about direct, and they were perhaps a little more inclined to make the effort because they had heard that there's a strong likelihood of getting a remission. And we see that in their control group in the TDMR trial as well. 12% of that control group actually did lose weight and gained remissions, which it makes the statistics more difficult, but it's a good result overall. There have been several studies which have looked at other dietary interventions and reported remissions of diabetes, and most of these have looked at low-carb diets. The biggest one, the Virta Health trial in the United States, which got these are sort of ketogenic diets. They got a very good weight loss, almost 14 kilograms overall, but their remission rate was very poor. Possibly 2 reasons for that. One, we know that in epidemiological work, that people who are on lower carbohydrate diets actually have more diabetes, a higher hemoglobin A1C. It has a metabolic effect to promote a more hypoglycemic profile. The other thing, of course, is that in that trial, it was not designed to look for remissions, and the patients tended to remain on medication. So some additional patients may actually have had remissions if their medication had been stopped. A GP in England did a remarkable thing, asking all the patients with diabetes in his practice, 473 of them, to go onto a ketogenic diet, and about 128 did. And they were able to, we don't know how much weight they lost, but at 2 years, 12.5% overall were in remission. And that was 46% of those who persisted with the diet. That would be equivalent to 73% in direct. So it's a slightly unusual way of looking at the analysis. If the people who stuck with the diet in the direct trial, 73% were in remission at 1 year. A couple of other studies, I mentioned only just in passing the Look Ahead trial, the biggest study ever conducted in the United States. They got around about 11% remissions with a weight loss of about 7 or 8 kilograms. So where does this take us and where are we going next? We have recommendations already coming out from the European Association for the Study of Diabetes. They'll be discussed at the meeting in June and probably published very soon afterwards. These are grade-based recommendations which include recommendations for remission of diabetes as well as weight management. We have the 5-year results from DIRECT, which I'm afraid I can't share with you today. It's been difficult getting these results because of COVID and then Brexit, which caused great delays in our closing and getting the analysis done. And we have big questions about, and I think it will be no mystery or surprise to learn that the remission rate is going to be substantially lower after all this. But there is some suggestion that the clinical outcomes may have a sort of legacy effect to remain better. I can't go any further than that at this stage. We have new analyses which have looked at proteomics analysis, which have begun to tell us what's going on when people stop being diabetic, and it's a reverse of what happens when they become diabetic, but we have a shorter time scale and we can see in more detail what the metabolic factors and proteomic analysis are. We've also developed a genetic risk score for cardiovascular risk, which uses the direct data, and it turns out to be rather better than clinical predictions, and we can show that it improves with weight loss. We have in England a program for remission programs of people who are overweight with type 2 diabetes, and this is going ahead now, not yet evaluated, using a variety of different diet programs. And we also have research programs now going on in different populations, including South Asians in the standby trial, which has just completed, a study which is ongoing in Nepal amongst Nepalese people with type 2 diabetes, and another one I'm involved with Aboriginal people in Central Australia. So there's a lot going on with new data emerging. Already we have guidelines from a number of groups locally who have promoted remission with suggestion that this should be a priority for people with type 2 diabetes. This was not included in the AADA ESD guidelines last year, and it's worth noting that the guideline process had no input from people with diabetes. I think that's a key feature here, because it was the people with diabetes who were so keen to see remission achieved. That was their top target for research in the studies conducted by, and this is just a rundown of the priorities of research of people with diabetes in the James Lind Diabetes UK exercise, which was published about 4 years ago. A top priority: can type 2 diabetes be cured or reversed? What's the best way to do it, amongst the others? So at that point, I would say we don't have to use total diet replacement products. It can be done with foods. Our patients preferred to use a commercial product. They found it their confidence was greater than selecting foods and having to make decisions about it. But we can use foods, and we've done this with Scottish diets and with a diet in Nepal using traditional foods, no packaged or manufactured foods. So there's a lot of scope for invention and for new ways of helping people here. But I would like to just thank all the people involved with the direct trial. Here they are, particularly Diabetes UK, for funding this, and the donors. It was entirely done by charity funding, not by government or by commercial companies. So thank you very much indeed.
Thank you very much, Mike. There are one or two questions have appeared on the system, and one relates, for example, to the question of if somebody's achieved weight loss and the HbA1c is reduced, obviously, and that happens during the time of energy restriction, and then you introduce an increase in dietary energy intake. The general question is, are they likely to maintain their metabolic state even though their weight loss has been maintained, but their energy intake is going up? So obviously it will vary from patient to patient as what happens, but do you want to make a comment on that in terms of actually practically what happens? As somebody who is involved in trying to help people to go into remission.
If people's energy intake is increasing, then either they're going to gain weight or they have to do an awful lot of physical activity to counterbalance that. Now, what we found in direct, and this is not the first time it's been found, is that people with type 2 diabetes have great difficulty in maintaining chronic long-term aerobic exercise, if you like. They struggle, and that may be partly physiological, because people with type 2 diabetes have a relative excess of type 2 muscle fibers, and they just find it very difficult, very tiring, very hard to do the sort of endurance activities which are necessary to maintain a lower weight. So if people are going to increase calorie intake, they're going to gain weight. And if they gain weight, they will, sure as eggs is fishes, sure as eggs is chickens, they will get their diabetes back again if they regain weight.
There's also a question from Grace Ann Alijon, who says that the results with the formula diet are good, but it's sad that diet is not offered to people until they get a diagnosis of diabetes, and that of course takes us into the area of the whole question of prevention. Do you want to make a comment on that at this stage?
Well, I mean, absolutely. I mean, we chose to do this intervention at a time when people already have their diabetes up to 6 years after diagnosis, and we've shown 8 out of 10 or more can get free from that disease. Now, I'm quite sure that if you were able to get people to do it at the time of diagnosis right away, this would be far better. And indeed, if you could do it a year or 5 years or 10 years before that, as people are gaining weight, and we can identify people really quite high certainty now as those who are likely to go on to develop metabolic syndrome, both from family histories and from the pointers which came from the Finnish studies, for example. So we know who's running the risks. It isn't absolutely everybody who's overweight who will get metabolic syndrome, but we can certainly identify those. And if they can do this type of approach and maintain the weight loss, then we'll probably never get the disease.
Yeah, and we should say that there are online risk calculators. So, for example, Diabetes UK has one online. So, if anybody's interested in looking to see what their risk is, they can assess that online. Okay, we should move on. Thank you very much, Mike. We move on now to Gary Frost from Imperial College. He's clinical dietitian by background and practice, but now leads a large research team at Imperial College. And he, in addition to having I know quite a heavy teaching load, he actually does run a very large research group. So, Gary, would you now talk to us, please, about the problems associated with maintenance of weight?
Okay, thank you very much. Just before we start, a few disclosures which you can read yourself there. We have received some educational money from Cambridge. We've received money from Nestle and from a number of UKRI people. So, especially when we come to the middle of the talk, some of the actual work that we do there, we've been funded deliberately for. Next slide, please. So if you actually look at historically what people have said about weight loss maintenance, it makes a very depressing picture that very few people, although they may achieve significant weight loss within the first 3 months and perhaps even up to 6 months, very few actually maintain it over a significant period of time. I think this is now the actual major challenge. As Mike has pointed out in his talk, the tools to induce significant weight loss, dietary-wise, are there, or by bariatric surgery are there. But the challenge still remains around the actual, how do you maintain that? How do you keep the diabetes remission going? So next slide, please. And the question is this a major rail cross? Because there are great cynicism from some angles that, you know, the actual, is it really worthwhile doing when a significant number of people, or the vast majority of people, may not get the same degree of long-term benefit? As you can see, these are two statements taken from one from a paper and the second one from a very personal review at the time. And I think what we can say is that perhaps things are challenging, but perhaps they're not in the same league as what's put here. Next slide, please. If you look at most of the studies that have been done where there is long-term weight outcome, or randomized control trials where there's long-term weight outcome, you will see this U-shaped curve. Mike's already presented the direct study, and as he pointed out, direct try to actually mitigate weight gain by having packages of care that people could drive their weight down. But nonetheless, even then, those people that didn't engage with the program, which is, I suppose you'd say, is hardly surprising, gained significant amount of weight. And the point of this slide is that here we have a variety of dietary interventions or pharmaceutical interventions across these studies, which actually induce weight loss. But as you can see, the vast majority of them actually result in significant weight gain between that period of 6 months, 1 and 2 years. So again, if we're going to try and achieve what Mike said, which is true remission over a long period of time, this has to be a focus, a serious focus of research. Next slide, please. So the question is why? Why is it when people have done so well in these studies do they actually regain weight? Next slide. And I think the actual question is not really fully understood. We have pointers to the phenotype, perhaps, of, if, for want of a better word, or the type of people that are likely to do well or not so well. So this slide has been taken from a collection of data from the National Weight Control Registry in the United States. And what it actually points to is a few items where the people who have done well, and we were just discussing this before we came in, you could argue that people that have maintained weight over 2 years are unusual, but nonetheless there are patterns that are emerging here. The first thing to say, the longer your weight loss goes on, the more likely you are to actually keep the weight off. So those people that actually maintain weight loss at 2 years are more likely to maintain weight loss at 3 or 4 years. We'll talk a little bit about physiology in a few slides' time, but the psychology of eating is incredibly important. And emotional regulation, how you approach your diet, how you cope with actually being in an environment where you're surrounded by very high energy dense foods, is actually very important. And there's a relationship between being able to control that environment and long-term weight maintenance. There's a relationship with depression as well. So obviously some psychological support or understanding the psychology around weight maintenance and the relationship with food is very important. Those people who actually maintain weight tend to be people who are consistent with their diet plan. So they don't have breaks. They're people who tend to actually keep the same pattern all the time. So rather than you say, I'm going to have a weekend break, those people that tend to do well tend to be people who maintain the consistency of the diet. Weight gain management, as you've heard from Mike, is very important, that you actually have a system that you can employ if you gain a little bit of weight. And really important, there seems to be the contact with the counsellor. And the importance of actually having a face-to-face contact with someone who's supporting you cannot be underestimated. Most of the long-term studies, the greatest success is seen in those that have the most contact, which is a challenge, a massive challenge from those providing healthcare. Next slide, please. And this again, just a nice little summary of those that actually have maintained weight, covering a number of the things that we've actually talked about already. Quite a few of them are psychological issues. Some of them are about regularity of eating, which we've talked about, and maintenance of the diet. Next slide, please. And the one thing to say is that what we're expecting people to do is, if they've gone through, say, something similar to the direct system, is to have this very unusual eating pattern to then be supported, to maintain their body weight, and then to go back into an environment which is full of very delicious foods, for want of a better word. And be expected to control their food intake over that period of time. And I think we've underestimated just how difficult that is, how difficult it is to move away from what has been an ingrained way of eating for a number of years. And I think we have very little insight in how to support people over that period of time. Next slide, please. And some of the issues aren't spoken about to patients, I don't think, very well, or people who are trying to actually lose weight over long periods of time. I think that the very fact is that the longer the weight loss period, obviously the more weight that someone loses, the greater the impact on their energy expenditure. So if you become thinner, you're not expending the same amount of energy. But if you look at those people that have modeled the drive for appetite, that increases at a greater rate. So the ability to actually overcome the weight that you've actually lost becomes more and more difficult the more weight that you come. So you could argue that your physiology is working against you, and unraveling the biology, the psychosocial aspects, the environmental aspects of long-term weight maintenance, that now becomes an absolute priority. Next slide, please. So you can argue that this is all wrapped up in survival of the human species. Why would we have mechanisms that actually allow us to decrease our food intake over long periods of time, when for most of humanity, survival has been actually dependent on eating and consuming as much food as we can at times when it becomes available? So are we faced with kind of old physiology or inherited physiology in a new food environment? So next slide, please. And if we look at what we have controlling our central appetite regulation, so this is slides that are common from the group that I work in, Steve Bloom's team, where they are actually putting the actual signaling, the gut hormone signaling from the gut. And most of these hormones like PYY, GLP-1 are anorectic hormone. There's only one that actually drives you to eat, which is ghrelin. All the rest are around actually trying to actually keep the food systems actually going. So you have lots of signals coming from the actual brain, which are monitoring food intake. So if you decrease the amount of stuff flowing through the GI tract, what tends to happen is that you see a rise, a decrease in the anorectic hormones and an increase in the erexogenic hormones, driving hunger. And that's exemplified. Next slide, please. By this beautiful little study that looked at a number of years ago now. If you just press again and we'll bring the full slide up. What you have here is a long-term weight loss study where people are falling, the body weight's Nadia's 8 weeks, and then you see this slow regain here. These are people who managed to keep, these are people, the total cohort. So if we just look on the other side of the slide, this is PYY. So this is peptide YY. This is an anorectic hormone. And what you see here is that the anorectic hormone drops. So the red line is when the body weight's at its lowest. So you see this hormone that's meant to actually suppress appetite decreases with weight loss. So the tone favors you overeating, and it doesn't come back. You can see that these hormones are suppressed even when the weight starts to come back up again. The same for CCK. And you can also see that the erexogenic hormone, that hormone that drives you to eat, acts in the opposite direction. So you actually have a rise in this hormone. So this is your physiology actually saying that you're from the state where you are, that you're hungry and trying to actually drive you back again. Next slide, please. And the same is true to many extent. So this is work that's done by Tony Goldstone here as well, that looks at drivers of liking and wanting. So how the brain behaves. And we know that, With longer periods of fasting, the liking and wanting for high calorie foods go up, which is again to a higher extent with overweight people. So you've got two things going on here. You've got signals from the gut actually affecting the brain. So you have this decrease in anorectic signals. At the same time, you have the brain actually wanting to you to consume higher energy foods. So next slide, please. So what we've been interested in is trying to say, well, can we nudge people in the right direction? Can we use some of this physiology to actually understand how we might be able to use signals from food a little bit better to suppress appetite and to actually drive perhaps the actual body weight loss over a longer period of time. And this is a neuroendocrine cell. This is the cells that actually produce those anorectic hormones, PYY and GLP-1. And they have a bunch of receptors on them. And the ones we've been interested in is the ones that actually look at breakdown products of carbohydrates. So these carbohydrates, such as dietary fiber, broken down by the microbiota. Could I have the next slide, please? And that actually creates a series of molecules that actually influence appetite regulation. And this is one of the studies that we've done. This is a dose-finding study for a dietary fiber called inulin. And what's surprising here is that in humans, you don't see an appetite suppression effect until you get to large doses of dietary fiber. So inulin is a refined form. So this is probably equivalent to eating about 70 grams of dietary fiber per day, which is, as you know, the actual normal intake in the UK is about 18 grams. So again, the gastrointestinal disturbances of this, at least in the short term, make it very difficult for people to achieve. But nonetheless, high amounts of dietary fiber, which is the stuff that causes these actual molecules to be formed, actually has an effect on appetite regulation. Next slide, please. And again, this is just a summary of it. So we've got dietary fiber coming through the small intestine, gets into the large intestine. The bugs in the large intestine ferment it, and they produce these short chain fatty acids. Next slide, please, to actually decrease that then hit these endocrine cells to release the actual gut hormones. So one of my colleagues and friends in Glasgow developed a very clever molecule. Could you just press again, where we've actually taken a dietary fiber, the inulin, and we've actually stuck this short chain fatty acid, so this active ingredient that's produced by the microbiota, to this molecule. And this way, it hitches a ride on the molecule until it gets into the colon. Then the bacteria eat up the inulin and release the molecule. And what we hoped was that we'd see a suppression of appetite. Next slide, please. And that's exactly what happened. So here you've got the actual PYY. Nothing happens until this molecule gets into the colon, and then you've got the spike of this anorectic hormone. And the same for GLP-1. Next slide, please. So delivering this actual short chain fatty acid into the colon actually has a measurable effect on these anorectic hormones. And then, although this isn't weight loss maintenance, this is prevention of weight gain. What we've actually shown in the first in human studies is that you make a significant impact on weight gain over 6 months. So giving the inulin propionate ester, so increasing the propionate in the colon of these overweight volunteers, enhances weight maintenance in these people. Now, this is not the same as actually weight loss maintenance, where you've gone through a period of great hypocaloric lifestyle. So it remains to be seen whether this molecule can help it. We believe it does. So next slide, please. And we also know that this molecule has an effect on liking and wanting. So giving the bowel a lot of propionate decreases the liking for high-calorie foods. So again, those two things that we exemplified go wrong in people that are going through periods of weight loss maintenance. We can influence with this novel food ingredient. Next slide, please. And we can show that we can maintain the energy difference. So next slide. Is it all doom and gloom then as far as it? I don't think it is. I think we can actually look at the science behind what people eat, and we can actually use that now to actually design novel ways or novel food ingredients. I think one study is kind of slightly being forgotten. This is a Diogenes study. So what Diogenes study did was they induced about 10 kilograms of weight loss here, and then they randomized people to a series of a mixture of glycemic index and protein diets. So low protein, high glycemic index here, high protein, high glycemic index, low protein, low glycemic index, and then the high protein, low glycemic index. And again, although this is a relatively short period of time, just 6 months or so, what you can see is that there is this combination, which is quite interesting, of the high protein, low glycemic index diet that actually seems to have an impact on weight loss maintenance. So again, this may be due to the actual change in the way that appetite is signaled because of the actual low glycemic index diet contains high fiber foods. The amino acid profiles actually have an effect on anorectic signaling. So again, I think, you know, this needs to be reproduced, but again, it's pointing in the right direction. Next slide, please. So in summary, what do we have? Well, long-term maintenance of weight loss needs to become the primary challenge of obesity management. We've got a huge number of tools to induce that acute weight loss. What we don't have at the moment is methodologies to extend the weight loss period. We need to bring together both the physical science and the social and psychological science if we're going to make a real impact. We need to ensure that people are aware of what the realistic long-term goals are. There's very good work to show that how disenchanted people become when they realize the actual amount of weight loss that they can achieve in the long term. So being open and actually counseling that, I think, is something that's very important. And the treatment of obesity requires ongoing attention and support. Again, there is a lot of work around trying to reduce the amount of human contact, if you, for want of a better word, in the management of people, because it actually becomes expensive. At the present time, unless some of my other colleagues know well, I think the actual evidence base is the more human contact you have in the management of people who are overweight and obese, the greater success of that particular program. Thank you.
Okay, thank you very much, Gary, for that very good review of the position. One or two questions have popped up, but in the interest of watching the clock, if you don't mind, I'm just going to take those right at the end.
Yeah, sure.
And we'll see what actually happens, because I can see that we could probably discuss some of those for 5 minutes or so. And I'm going to move on now to our presentation from Elena Philippou from Nicosia. Elena, by background, is a clinical dietitian and a lecturer at King's College in London, a visiting lecturer at King's College in London, but also a professor in nutrition and dietetics in Nicosia. Has worked throughout her career on diet in relation to disease, heart disease, cardiovascular risk, obesity, and has a particular interest in glycemic index diets and the Mediterranean diet. So Elena, we're very glad that you're able to join us this afternoon, and we look forward to listening to your talk.
Thank you, Tony. Can you see my screen?
I can see the screen and I can hear you.
Okay, great. I can start then. So my talk is on glycemic index and the feasibility of using low GI or low GL diets in Mediterranean countries to facilitate weight maintenance. So I have to disclose that I'm the editor of this book, The Glycemic Index Applications in Practice. So I think we all agree that the largest challenge in obesity management, and so also Gary presented, is maintenance of reduced body weight in the long term. And in an a systematic review just published, a meta-analysis on the effectiveness of behavior-intensive intervention, which included 8 clinical trials and randomized controlled trials with a follow-up of at least 12 months and about 1,500 participants. And they compared a group that followed a more intensive protocol to a control group. It was actually shown that in individual studies, maybe there can be a little bit of more weight loss in the weight maintenance period. But when they compared all the different studies and they looked at the difference with the control, they found that there was not a statistically significant difference of the effect size between the intensive and the control groups. And I think it was presented really well before by Gary, the reasons why it is difficult to maintain weight following weight loss. Just briefly mention again that during the weight loss phase, there are actually compensatory changes in the homeostatic processes that result in increased hunger, as was mentioned before, and reduced satiety, and perhaps also preference for more palatable foods. And at the same time, we have a reduction in the rest metabolic rate, as was also previously mentioned. And therefore, the cost of adherence relative to rewards of body weight maintenance is increased. And thus, we need education on lifestyle changes, including, of course, diet, but also physical activity, sleep, as well as stress management, social connections, and avoidance of risky substances. All the 6 lifestyle pillars need to be taken into account. And behavior approaches need to be started early during the weight loss phase. And also, I think we need a multidisciplinary approach to approach the weight maintenance. And it was also shown before, but I'll just show some further evidence of the changes in appetite after weight loss. So this study included 100 individuals with obesity, which followed 8 weeks of very low energy diet, followed by 4 weeks of refeeding and a 1-year maintenance program. And it was shown that during the time that they started eating again and trying to keep their weight off, there were significant increases in both the fasting and the postprandial hunger ratings, but also the postprandial fullness, as well as reduction in prospective food consumption. And as you can see in the figure, this fasting hunger and postprandial fullness remained increased even at 1 year. And here it was also shown that there was a significant rise in basal and postprandial active ghrelin, the hormone that makes us hungry, at week 13, which was also sustained at 1 year. So can a low glycemic index diet facilitate weight maintenance? So before we answer that, let's first look at what is the diet glycemic index, or GI, and glycemic load as well, or GL. So the glycemic index is a ranking of carbohydrates on a scale of 1 to 100, according to the extent to which they raise blood glucose concentration after eating. And perhaps you have seen this diagram before. After consumption of a high glycemic index carbohydrate, we have a rapid increase of blood glucose, followed a lot of times by a decline of blood glucose, sometimes even to below fasting concentrations. And this is important, as I will explain later. Whereas consumption of a low glycemic index food will cause only a low and steady blood glucose increase in our system. And I think the best way to think about glycemic index is by looking at oats. When we have rolled oats or intact whole grain whole oats or still cut oats, we have a low glycemic index of 48 to 55, but the glycemic index increases when we take instant oats, processed food. The glycemic index is a measure of carbohydrate quality, whereas if we want to be thinking also of the carbohydrate quantity, we need to be thinking of the glycemic load, which would be the GI times the amount of carbohydrate in the portion of food consumed, and this is divided by 100. And there's also a system of classifying GI and GL. So low GI food would be that has 55 or below GI, medium GI 56 to 69, and then 70 or above would be high GI food. And for GL, this will be, less than 10 or 10 or below low GL, 11 to 19 medium GL, and 20 or more high GL food. And this, of course, will change if we're thinking about the whole diet. So examples of low GI foods would be beans and lentils, pasta cooked al dente, whole grain seeded bread and rye bread, sweet potatoes and white rice, rolled oats, and most fruits such as apples, berries, plums, and nectarines. Whereas high GI foods would be white and brown bread, French bread, baked puree or fried potatoes, some types of white rice, especially jasmine rice, most breakfast cereals, some fruits such as melon, watermelon, raisins, and ultra-processed foods and drinks, and such as rice cakes, crackers, and soft drinks. So the effect of GI on weight maintenance in overweight subjects, I think the first that we looked at this was during my PhD under Gary Frost, supervised by Gary Frost, and we looked at it in a pilot study of 42 people that followed a 2-month weight loss using a formula low energy diet and lost about 6% of body weight. And then they were randomized to low or high GI healthy diets, and they achieved the high or low GI diets. And here you can see that during the weight maintenance phase, the low GI group lost a little bit more weight and the high GI group gained a little bit more weight, but there were no significant differences between the two groups. But this was only a pilot study. And although we concluded, of course, that changing diet does not appear to significantly affect weight maintenance, we needed more participants in order to have sufficient power and longer duration. So next, after that, it was the Diogenes study that also Gary showed before, looking at whether diets with high or low protein and GI can support weight loss maintenance. So as was mentioned before, they had 4 groups or 5 groups actually. They had also a control group varying in GI and protein. And they did an 8-week low-calorie diet. These people lost weight, and then they did a 6 months of maintenance, but they could eat ad libitum, so as much as they wanted. And there was evidence that their weight regain was about 1 kilo less in the high protein versus the low protein groups, and about 1 kilo less in the low GI versus the high GI groups. And this figure was shown before, that those people in the high protein, low GI group did better. Following this, we have now evidence from the previous study on dose-dependent associations of dietary GI and GL with 3-year weight loss maintenance, so longer period and higher numbers. The previous study studied overweight and obese participants with prediabetes, and they did an 8-week weight loss phase followed by 148-week or 3-year of weight loss maintenance, and they were randomized to high protein, low GI, or moderate protein, moderate GI. And this was combined with high or moderate intensity physical activity. And what I'm showing you here is secondary analysis of about 1,300 participants. Here they looked at the longitudinal associations of cumulative average GI, so each 10-unit increase with the yearly weight regain, and also the changes in markers of glycemic status during the weight loss maintenance. And they showed that GI, as you can see, was positively associated with regains in body weight and fat mass, and also increases in hemoglobin A1C and fasting insulin and HOMA insulin resistance. So the higher the GI, the worse the outcomes. And you can also see in this diagram where the higher the tertile of GI, there is a more increase in body weight and a worse outcome in hemoglobin 1C, so the glycemic control of these people. And similarly for GL. So can a low GI diet suppress hunger after weight loss? What is the evidence on that? Again, we have some evidence from the previous study. In this analysis, we have 220 participants. Again, the same intervention as mentioned before and the same groups. And if we first look at only the diet parts, so those people that were in the high protein, low GI group seem to have less hunger compared to those people that were in the moderate protein, moderate GI group. And similarly, if we also take into account the physical activity and after adjusting for potential confounders, the decreases in hunger ratings relative to baseline were significantly greater both at 1 year and 2 years in the high protein, low GI, high intensity group versus the medium protein, medium GI, high intensity group, physical activity group. So following a low GI and high protein diet seems to work for hunger. And then another secondary analysis of the same study, this time looking at 1,279 individuals merged into one group to look at the longitudinal associations of the yearly changes in appetite sensations. When they looked at GI only, so the quality of the carbohydrate, it was positively associated, as you can see here, with increases in the ratings of desire to eat something sweet. But this association was no longer significant after additionally adjusting for dietary factors and physical activity. But if they then, when they looked at in the same study, both the quality and the quantity of carbohydrate, so by looking at GL rather than GI, GL was positively associated with increases in ratings of hunger, desire to eat something sweet, and also body weight change. So it is no surprise that we need to be thinking for weight loss maintenance, both the quality and the amount of carbohydrate consumed. In this study, they also looked at, in a subsample, the fasting plasma concentrations of the total ghrelin, so the orexigenic hormone, the appetite increasing hormone, and the total peptide YY, so the hormone that reduces appetite, and also appetite sensations as people felt them, measured at baseline 2 months and then 6, 12, 24, and 36 months. And they found no evidence of any overall difference between the weight maintenance diets for both gut hormones. But this might come, it's no surprise to me because there's so many other biological behavior and environmental factors, as was also mentioned before, that might drive weight maintenance. So it's not just about gut hormones, but there are many other aspects. So we need to consider everything. So does a high GI or GL diet promote weight gain? What is the answer to that? So based on the carbohydrate insulin model proposed by Professor Ludwig and colleagues at Harvard Medical School, it is not a positive energy balance that causes the increase in adiposity, but rather a shift in substrates after consuming a high glycemic load diet. So when we're consuming a high glycemic load diet, we have an increase in insulin and a reduction in glucagon ratio, and the body basically goes into anabolism. So here there is an increase in fat storage, but as we mentioned before, a few hours after eating a high glycemic load diet, we also have a reduction in our blood fasting glucose concentration. So a few hours, so maybe 2 or 3 hours after eating, our body senses that the circulating fuels are reduced. And this makes us want to eat more high glycemic load or more sweets at that point. And there's also a reduction in energy expenditure. So then we have a vicious cycle that we have an increased energy intake and a reduction in energy expenditure, and also a drive to eat more high glycemic load foods. So I quote from the paper that restricting energy intake when consuming a high GL diet would neither lessen the predisposition to fat storage nor diminish hunger during dieting. Rather, by further reducing metabolic fuel availability, hunger would increase and energy expenditure may decline. So what is the solution to this? Is a Mediterranean diet a solution? And is it, first of all, a low GI diet? So let's first take a glance of what's the Mediterranean diet. The Mediterranean diet is a plant-based diet that puts a lot of emphasis on consuming whole foods and processed foods, legumes, fruit, vegetables, of course, extra virgin olive oil. Then we have nuts, seeds, olives, and herbs and spices. Dairy is consumed about 2 portions a day. And then on a weekly basis, we have more emphasis on white meat, and fish, and seafood, and very little processed meat and red meat, and of course, sweets and desserts. So the PREDIMED study, which is a randomized controlled trial of the Mediterranean diet supplemented with olive oil or nuts, and the outcome was major cardiovascular events, in this analysis looked at whether the Mediterranean diet is a low GI diet. And they found that the mean GI of the diet was medium, so low to medium GI, and the mean GL was also low to medium. And in multivariate adjusted models, they showed that there was an inverse association between the GL of the diet and the Mediterranean diet. So the higher the adherence to the Mediterranean diet, the lower the GI and the GL of the diet. And when they looked at the different food groups that actually increase the GI or GL of the diet, within the cereal group, it was mostly bread, either white or whole grain bread, fruit, and then potatoes came after that. And I think the next question that we need to consider is whether we are actually following the Mediterranean diet, even within the Mediterranean countries. So in this study, we had 3,000 adults from 7 different Mediterranean, including Cyprus countries. So it was Spain, Portugal, Greece, Italy, and Cyprus, and non-Mediterranean countries, Bulgaria and Republic of North Macedonia. And we looked at the adherence to the Mediterranean diet assessed using the MEDA score. And we found actually that even within the Mediterranean countries, adherence to the Mediterranean diet was only moderate. And in non-Mediterranean countries, it was weak. And also we saw that food groups that are associated with the Mediterranean diet, such as fruit and legumes and nuts, and will also reduce the GI of the diet, were not consumed to a high extent. And then foods that would be associated with a low adherence to the Mediterranean diet, but also would increase the GI of the diet, such as desserts and sweets, as you can see here in red, were consumed by a high percentage of people. So what is the feasibility of a low GI or GL diet in the Mediterranean region? I think we have, in the Mediterranean diet, we have a treasure, and this is legumes and lentils. And we need to put emphasis on consuming legumes and lentils as part of meals, but also as main meals, 2 to 3 times a week. You can see some lovely pictures here. And then we can also look at how to reduce the dietary GI within the Mediterranean diet to make it more healthy. So for example, some practical solutions here would be instead of consuming white bread, which has a high GI, we can consume whole grain seeded bread, which has a low GI, and we can use that in salads and other dishes. Another example would be instead of consuming baked potatoes, which have a high GI, we can substitute it with boiled sweet potatoes, which have a medium to low GI. Another possible way would be to substitute couscous with quinoa or bulgur wheat. And also some high GI fruit, which are consumed sometimes in high amounts, such as watermelon, raisins, and dates, with low GI fruits such as strawberries, berries, apples, plums, nectarines, and grapefruits. And then also, if we want to be thinking about reducing dietary GL, we can substitute sweets and processed foods and obviously high fructose corn syrup containing soft drinks with avocados, nuts, and seeds, which would reduce the dietary GL as well. And I also have here a very simple diet plan of how would a low GI Mediterranean plan look like. Of course, there are many possibilities, but I put something together. So for breakfast, one could have a whole grain seeded bread topped with avocado, some black olives, some tomato, and a glass of milk, some apple and almonds for snack, a lunch with a salad of fresh vegetables, lentils, and quinoa, boiled egg for protein, and extra virgin olive oil, of course, and an orange. Snack could be live Greek yogurt topped with walnuts and topped with a tablespoon of rolled oats and cinnamon. And dinner could be chicken fillet marinated in yogurt and oregano, bulgur wheat, or perhaps fresh fish instead of the chicken. A Greek salad with a small amount of feta cheese, and of course extra virgin olive oil, and perhaps a glass of red wine as well. So it's some take-home messages to finish off. Long-term weight maintenance is a challenge, but reduced diet GL and GI are associated with better weight and fat mass outcomes through reduced hunger and desire to eat something sweet. And of course, physical activity is vital. So policies should aim to support people in choosing low GI Mediterranean foods, aiming to reduce, of course, the obesity pandemic. Thank you very much.
Thank you very much indeed. And that gives us lots of ideas for how to make changes. But one of the immediate thoughts is that, bearing in mind the population sizes and the volumes of foods that are required to do this, how realistic do you think it would be to actually move towards the reversion to the sort of typical diets of 50 to 70 years ago, where more legumes were consumed? Because it has big implications for agriculture, doesn't it, as well as, and retailing and advertising and consumer attitudes and so on. So it's very complex, isn't it, to make these big changes?
Absolutely.
Are there any suggestions that you have?
Yeah, I mean, it is very difficult. And I think we need to consider changing the food environment and offering options that are plant-based. So, for example, supporting restaurants and schools, school meals or workplaces to offer plant-based options versus the meat, so people would be able to choose better. And there are also many other ways, such as reformulation of foods, promoting the non-processed foods. Of course, technology and media campaigns need to be considered. So I will stop there because there are many different options that we can use.
Okay, thank you. My suggestion now is that we actually go to the panel. I'm watching the time, of course. If we could do that, a general question and answer. We've had some other questions that have come through. If we can get everybody available. Yes, good. One question that did come up was whether there is any environment in the world that provides evidence that weight maintenance is easier when all those external factors that you showed in that very complex figure, Gary, when those are different. But I think everywhere, almost everywhere in the world has changed. And we know that even in low to middle income countries, there are subsections of the population who express obesity and obesity-related comorbidities, just as happens in Europe and North America and so on. So I'm not sure there's any evidence from that, and it would be immensely complicated to sort it out anyway, wouldn't it? So that's for Gary to start with.
Yeah, I think you're absolutely right, Tony. The very worrying thing, as you said, is that in very many low to middle income countries, especially when they go through increasing wealth, you start to see the same patterns occurring of what you do in wealthy countries. So no one has got the actual true evidence behind those suggestions. They've been pulled from more epidemiological studies or derived from randomized controlled trials where they've specifically looked at people who have done well or not so well. So it's an open question. And you know, Mike spent many years getting direct off the ground. And I think it's the same issue here, is that we need to actually have a coordinated approach. It's targeted at weight loss maintenance and actually putting some of these things into practice.
Mike?
Yeah, I mean, you're absolutely right. Looking right across this over a sort of lifetime of research, there has been a lot of money spent both on clinical services and on research for the complications of obesity. Many complications of obesity, whole medical subsections addressing diseases which are actually complications of obesity, money pouring into them. A little money has gone into treating obesity, and trivial amounts, almost nothing, into how to do weight loss maintenance. And even now, there is no indication for treatment, which is weight loss maintenance. So if you have a new drug for obesity, it has to be for weight loss. You cannot get an FDA license for weight loss maintenance. And the same in EMA. So I think as a revision of our thinking about what this disease process is, it's not just having a BMI of, and so many people have thought obesity equals a BMI of 30 or equals a BMI of 28. It isn't. It's a disease process which starts with genetics, epigenetics, and then environmental factors, of course. It's a disease process throughout life. And it doesn't suddenly start with a body mass index of a certain level. And what we're trying to do is to reverse that disease process, which is effectively weight loss maintenance as early as possible, ideally long before the BMI ever reaches BMI 30.
Mike, some of your other work, I know, is involved in trying to identify those at risk during adolescence. Do you want to just comment on that? I know we don't know the full results yet, but...
Well, I mean, in general, identifying people at risk of metabolic syndrome, which includes, of course, ultimately diabetes, hypertension, premature heart disease, a whole gamut of ghastly complications, and indeed extra cancers, is something which is under a lot of review from genetic scientists in a number of centers around the world. But we already know that if we identify people whose waist circumference is increasing, they are very likely to be those who are accumulating ectopic fat in the liver, in the pancreas, in internal sites, in the sites of old brown adipose tissue. These are the people who are very likely to gain weight, and if they do gain enough weight, will develop diabetes and the other complications. So we can identify them relatively early just by having a high waist circumference. And that was a piece of work we did now over 20 years ago, which was allowing us to identify people. So, for example, people leaving school, you can do it with body mass index. If school leavers have a body mass index which is already 25, it is highly likely that they will go on to become obese, and a high proportion, almost half of them, will have the metabolic syndrome. This is a very common condition. About somewhere between 40 and 50% of all people, European descent and more in Asia, have the genetics for metabolic syndrome. If they gain weight, it will turn up in time, some younger, some older, but it will happen. So it's all part of that same disease process, and we need to get through that, the thinking that this is a cut-off disease, it's a state of obesity, and to start dealing with the disease process. So weight loss maintenance is exactly the same as primary prevention. And I'm afraid the big driver to the epidemic, the pandemics, or the syndemics of type 2 diabetes, obesity, is the sort of post-industrial food revolution, which has allowed, surplus food, too much food to be available to everybody. And we have appetites, which I think Gary mentioned. We have evolutionary appetites, which will cause us to gain weight, because in evolution, this threat is always going to be a famine.
Yeah.
And the people who survive famines are either people like me who can run across mountains, and that's very good, but not many people do that. The other solution is to gain weight when there is food and to sit out the famine. And that's how our evolution has given, we are a social species, so some people can run up mountains, the majority will gain weight and sit it out in a cave. And I think that's a simplistic way of looking at it.
Yeah,
But
I should add that you're one of the people who runs up mountains.
I do.
For the benefit of those who don't already know.
Perfectly normal to gain weight. It's absolutely normal.
Yes.
This, what we call a disease process, is only now a disease because there are no famines, because we have food. Yeah, we have food in petrol stations, in laundrettes, every shop in the corner, and we're encouraged to buy more than we need.
Yeah. Can I just ask Elena, based on the evidence that's there already, do you think there's any justification for actually working towards using low GI, low GL diets for weight maintenance, along with all the other many factors? And I know that in preliminary discussion, Mike pointed out that that's just one of many factors that we can manipulate. But do you think there's enough evidence? And secondly, if it were to be done anyway, it's not going to be a harmful change in diet, is it? It's going to be a beneficial in many ways, in other ways as well. What should...
Yes, I think there is evidence to support that. And as you said, this is actually, we have also evidence that this type of diet is healthier. So definitely it will be beneficial, but there's going to be also a provision of more nutrients by choosing low GI foods, such as the ones I showed before, and avoiding ultra-processed foods, which a lot of times there's nothing to them apart from sugar and fat. There's no actually any nutrients to them. So I think that is a way forward.
Yeah. Mike, did you want to comment on that?
Absolutely. Low GI diets is one aspect of traditional eating patterns. So we can talk about Mediterranean diets or Nordic diets, but traditional eating habits, traditional diets, by and large, are associated with a freedom from type 2 diabetes, a freedom from obesity, and with a low energy density, and with a low glycemic index. So it's a descriptor which suits all traditional diets. And I prefer to think of it in terms of moving towards a respect for and a celebration of traditional eating habits, eating patterns, rather than slightly scientific notion of a low glycemic. I know we can analyze it as a low glycemic index diet, and of course that's useful scientifically, but as a message to the public, I think celebrating traditional foods and traditional diets is the way I'd like to go, and not just to do it on holidays or special occasions, but to make that the norm. So isn't so difficult. It really isn't so difficult. And in Scotland, we have some very traditional foods that nearly everybody likes, but they've been lured down a different route. So everybody actually, if you give them porridge every day, they love it. Everybody loves porridge if you have it every day. And I'll challenge you, all of you people who say, oh, I don't like porridge, have porridge every single day for a week. And at the end of the week, you'll be looking forward to your next bowl of porridge. Then our most celebrated mealtime food in Scotland would be soup, lentil soup. Why lentil? It's filling, nutritious, it's got all that stuff. And again, if you give people lentil soup every day for a week, they will be longing for their next lentil soup. And appetites can be moved towards the traditional foods. And the same applies in any culture. Traditional foods have value. Nutritionally, remarkably, they're usually pretty good.
Yeah. Gary, do you want to comment on that?
No, I was going to make a facetious comment about deep fried Mars, but I won't.
Well, yeah, there are some strange foods as well. I should tell you,
by Americans for touristic purposes. That's right.
Can I just ask before I'm just looking at other questions? Some have come up just before I look at some of those additional questions. I'm going to allow us to run over for 5 minutes or so. Are there any questions any of you want to ask each other about your presentations?
I suppose it'd be interesting to know if you were if you were to think of just one thing that might make a difference at the present time, what would that be? You know, what would you put in place to try and improve weight loss maintenance and push out the actual diabetes prevention or diabetes remission? Sorry.
I don't know who you're asking that to.
Well, both of you.
Well, what I would say first is asking. This is a kind of question that politicians ask. What's the one?
Well, that's the reason for asking it.
And this is just a complete lack of understanding that complex problems are not solved by one thing. And this is kind of facile thinking, which I'm afraid politicians kind of bat it around as if there's a magic grail out there. So, I mean, if we're going to get rid of type 2 diabetes, I think we have to do something pretty radical to the eating patterns which have been developed in post-war Britain. And I keep saying, when I was at school, I'm interested in Elena's point of view on this. When I was at school, we would have been punished if we had been seen eating between meals. In uniform, in school, you don't never eat between meals. It was completely wrong. It was culturally wrong. We didn't do it. Now, marketing of fast foods means every child is sent to school with a snack to eat between meals. And we've become accepting that this is now normal. And that's going to...
You've just lost the sound. Elena, do you want to just comment on that?
I think, I mean, to add to what Mike just said, and kind of even worse, is that children also eat in school without their mothers knowing. This is what happens. They get other food from their friends and they eat that. I think there's no one answer that I would say, but I can say one word, which is lifestyle. So I think people don't realize that they need to make lifestyle changes and keep the lifestyle changes if they want to lose weight or maintain weight. I mean, sometimes people think that it is going to happen, like that, but it takes effort, and it will also mean changing the way you live. So I think all the different lifestyle pillars, stress management, finding ways to combat what we mentioned before, emotional eating, for example, is very important, but also other things such as social connections. You mentioned before, going out for walks with people. It's extremely important. Exercise, but also social connections and sleep and everything together. It cannot be one thing.
The question has come up about for the United Kingdom, the NHS, the diet plans which are high carbohydrate. Does anybody want to make a comment on the official guidance that we get at the moment in relation to guidelines? I don't know what the position is in Cyprus, for example. Mike?
Well, what we know about carbohydrate is that extreme levels of very high or very low carbohydrate are associated with worse outcomes, more cardiovascular disease. So don't go for the very extreme ones.
Yeah. What is the official guidance in Cyprus?
Do you mean the percentage of carbohydrate in the
well,
diet?
no, I'm just thinking, what sort of guidance do you get from the Ministry of Health, for example, in Nicosia? But is it up to date in terms of the guidance, or what is known?
Yeah, I think it's the usual one, 45 to 55% of carbohydrate in the diet, and then 15 to 20% of protein, etc. Less than 35% of fat is usual, but I think it's food-based guidelines now, rather than percentages.
Yeah.
I think Gary wants to say something though.
Yes, Gary.
Well, I was just going to highlight it's also about for want of a better word, the carbohydrate quality. It's how that carbohydrate presents. That's important. Whatever you call it, whether you call it low glycemic index or you call it traditional eating, where grains or seeds are actually consumed whole, that makes a massive difference, and is probably more positive associated with.
There's a comment from Scotland which says, make it a scandal to be seen walking down the street eating. It was just never done. So somebody agrees absolutely with you, and I certainly agree with you from my childhood as well. It was unacceptable.
Whereas, if I may add, actually, when I first came to the UK, that was something that it surprised me, because we're not eating while walking here, but in Cyprus, but we don't walk so much though. Also.
Yes. And that brings us to physical activity and the guidance for physical activity in relation to weight loss. Do you want to make any comment on that, Mike? Because I know that you're very enthusiastic and very keen that physical activity levels should be adequate, but we've got to get the whole population up to that level, which is very difficult.
Yeah, it is very difficult. We made a big effort in the direct trial to try to encourage physical activity based on the weight loss registry. Jim Hill and Rena Wing's study in the United States. They found the best weight loss maintenance was in people who were doing 15,000 steps a day. And interestingly, one of my PhD students, William Tigby, did a marvelous study looking at physical activity in postmen. And he found that the postmen who were doing 15,000 steps a day, that's 6 to 8 hours on your feet every day, they were the ones who were free from diabetes, free from high blood pressure and such like. But that's a very high level. And we found in direct that our participants, even though we encouraged them, we gave them step counters, and we encouraged them at every visit, they did not increase physical activity. So it's very difficult. And as I mentioned this earlier, there is very old evidence which says that people with type 2 diabetes, this is a metabolic difference across the whole body, of genetic origin, they have an excess of type 2 muscle fibers. Now, type 2 muscle fibers are the kind that make you jump high, throw things a long way, and you win the school sports at 100 meters, but you cannot run a mile. So these are the people who have good muscles for explosive activities, and they'd be very good for sort of fighting shorthand, but not any good for running away. So they have survival value, but not all survival value.
Yeah.
People who simply find it really hard to maintain endurance activities. And I think that as much as we can encourage them, they find it very hard to maintain that. So physical activity is really not effective.
Good. And then just a last comment from somebody and a question. Average dietary fiber intakes in the UK are about 18 grams per day. How realistic is it to increase those across the whole population in order to facilitate appetite regulation and prevent weight regain? Is it realistic to go up to the higher levels, which are already in the recommendations, of course, for the UK and I'm sure across Europe as well?
Okay.
Gary, do you want to do that one?
Yeah. Well, I think it is realistic. I think it will take a shift in the food systems, just as Mike was saying before. You need to nudge people in a positive way towards this. The issue is that we've had several generations that have grown up with the manufactured food. Whichever way you look at it, foods that have a high fiber content and are consumed as a whole seed or a crunch seed taste different. And people aren't used to that taste, and to develop it will take time.
Yeah. Okay. I'm going to conclude now. Zoe, could you please put the 2 slides up, starting with the first one, concluding remarks? So quickly go through these. Our speakers have discussed these, and we recognize they're not complete, but essentially, We know that diabetes remission can be achieved in some population groups around the world. There's a need for a little bit more study. We also know that the initial weight loss is very important, achieving enough weight loss, and that determines the effectiveness in terms of remission, and also indeed in prevention. The amount of weight loss is critical in prevention and reversal of metabolic and pathological changes. We do know something about the characteristics of weight maintainers and regainers, although Mike earlier pointed out that in fact we don't have huge amounts of evidence about those small proportion who can actually achieve weight maintenance. We accept that regain is normal in the sense that it's what happens to most people, and what we need is a portfolio of support to help people. Reduced dietary glycemic index and load are associated with better weight and fat mass outcomes through affecting hunger and desire to eat something sweet, as Elena discussed. And unfortunately, it is the case that the adherence to the Mediterranean diet is only moderate, even in Mediterranean countries. May I have the next slide, please, Zoe? And then from that, we then get to the question of next steps. What are the questions that we should be asking ourselves? How do we help the non-responders, those who weren't able to go into remission? Well, in the direct trial, of course, there were various rescue packages, and perhaps there's scope for developing these to an even greater degree. In non-European populations, how do we achieve weight maintenance and indeed remission, bearing in mind that the diets have to be culturally appropriate? And you saw some slides from Mike showing the diets that we're proposing to use in Nepal. And how do we convert the weight regainers to weight maintainers? All sorts of variables, including exercise, screen use, which is a critical one, sleep, and then also the behavior in terms of timing of eating during the day. How can we enhance the physiological systems with food components? That's an area which we'll develop further, referring, of course, to Gary's work on inulin propionate. And how do we support people to avoid emotional eating? That's a very difficult one. I'm not sure anybody truly has the answer to that, but we need to work on that. And then following the results from the previous study, should we introduce low GI, low GL diets at this stage, or do we need yet more work, bearing in mind that Preview was a huge study on initially 2,200 people in 8 different countries. And then, of course, the final comment that relates to my question that I put to Elena: can we have a joined up EU-wide policy for farming, retail, advertising, consumer choice to revert Southern Europe towards the more traditional lower GI, lower GL diets, with perhaps Northern Europe following? Although I do know, of course, and many of you know, that Anna Astrup has tried to introduce a new Nordic diet for Denmark, and indeed has been fairly successful delivering that in schools and so on. The note I put at the bottom relates to some evidence that's going to be presented on the 4th of May in relation to sleep and weight, which will be useful. But Mike has also pointed out to me earlier that there are lots of interesting things that we presented at that meeting in May. So maybe some of you would like to attend that. So it remains for me to thank you all for your participation. Thank you to each of our speakers, Elena, Mike, and Gary, for preparation and for the presentation of these very interesting talks, which will be available online. Thank you to our Secretariat for managing this process behind the scenes. And then also thank you to you as delegates for attending. We will address those questions which you which we didn't answer during the course of the meeting, and also we will make sure that all of those who attended know where to find the materials. And I apologize for the little technical hiccups that we had at one point, but I don't think it was too damaging. So I wish you all well, and thank you very much for attending, and hopefully we're going to have another one of these in 4 to 6 months' time. Thank you very much. Bye-bye. Bye. Thank you.